One of the things I've noticed with adrenal imaging, when you think about it, most adrenal lesions we're going to see are going to end up being benign, right? They're simply going to be adenomas. And we see them every single day, several times a day, and no one gets all that excited about them. But I will say that adrenal imaging is at times extremely difficult in the sense that when I notice we have adrenal conference every other Friday. We do somewhere between 6 and 9 cases. It's radiology, pathology, endocrinology, surgery, and the medical side of things. And no matter how many adrenals I've seen, there always are some adrenal cases that are brought up that are just really hard to figure out what to do with. One of the things, and we'll speak about that a little bit more in a second talk perhaps, is you really don't want to be doing adrenal biopsies if you can help it. Remember that adrenal cortical carcinoma, we always worry about that, high morbidity, high mortality. The challenge with adrenal cortical carcinoma is you biopsy them, you seed the tumor. The surgeon can't do a total adrenalectomy and patients will have tumor spread. So you really want to avoid biopsies and indeterminate lesions unless you're pretty certain it's not an ACC. So it makes things very difficult. CT is the mainstay of looking at adrenal masses. MR and nuke studies can be very helpful in cases where there are questions. Again, the things we think about, the majority again are going to be benign, but it's often up to radiology to really figure out how to manage these patients. One of the things also to recognize is, and this is perhaps where radiologists and endocrinologists do differ, and I'll show you some articles about that, but radiologists, we tend to focus on the imaging, looking and saying, aha, this is a adenoma, there's no problem, next case, move on. Endocrinologists tend to think about things a little bit differently because the main quote from the endocrine workup is that, hey, picking up an adrenal incidental finding may be that that's an incidental hyperfunctioning nodule. We never really think about that. If someone said to us the patient has hypertension or they have a number of different symptoms, then we think about, could this be a functioning lesion? But when we see routine lesions, we're thinking adenoma. In the spectrum of things, when you think about benign lesions, we'll also talk about things like myelolipomas, which are always benign, but do have the complication of bleeding. So they'll need to be resected, particularly roughly over 5 centimeters. We'll think about cysts. We'll think about enhancement because one of the lesions we'll commonly pick up will be pheochromocytomas, although everybody thinks about pheochromocytoma as a patient with hypertension. 70% of all pheos are incidental findings. So how do you recognize and distinguish a pheo from an incidental adenoma becomes important. Obviously, metastasis is something we think about, but invariably, they're typically going to be in a patient where we have a known malignancy. And then we'll speak about, particularly in the second talk, which will focus mainly on large masses, we'll talk about some of the malignancies and how to be very specific as to what those malignancies are. One of the things, there's a recent article in Radiographics made the point that we were very comfortable for many years looking at lesions and size and cystic nature of lesions and very comfortable basically pushing most lesions off as benign. But as I'll show you, there's a lot of overlap, so I think you need to be a little bit more careful. If you ask what things do you look at when you're looking at adrenal lesions, we're going to look at, if you thought about whether it's a non-contrast or contrast, you're still going to look at attenuation. That probably is our strongest single value. Lesions well-defined that are under 10 centimeters, that are under 10 Hounsfield units, under 4 centimeters, are typically going to be benign. It is possible to have a measurement of 10 Hounsfield units in a cystic pheochromocytoma, but then invariably the lesion is going to have peripheral enhancement, so you're not going to make that confusion. But there is some overlap, and we're going to show how to look at that and how to figure that out. And again, one of the things, how many of you, just by a show of hands, go to multidisciplinary conference for adrenal? Is there anybody else? So it's Yeah, nobody. So it's interesting, or maybe one person, but we are doing that. And again, we've been doing pancreas for 15 or 16 years. We've done adrenal for about 7, but it does work out. So if I ask you what's a normal adrenal gland, we all know it. It's usually less than 2 millimeters or 3 millimeters in thickness. The adrenals look different from right to left. We know the length of the adrenal is not going to be important. Some limbs are very thin, some are thicker, lots of normal variation. If you measure the adrenal gland normally, if you took these normal adrenals and you had non-contrast and you had arterial phase, although we don't think about it with any great detail, adrenal glands typically will enhance. So most of the time, if you would measure a contrast-enhanced study, the adrenal gland probably goes to about 50 Hounsfield units. But we look at it and we know it's normal. On the other hand, when you see very bright adrenal glands, when you look at adrenal glands that look like they're just as bright as the aorta, you know that's abnormal. And that's typically in a patient who's hypotensive. And this was initially described in pediatric patients post-trauma. And you can see in this case, this wasn't a trauma patient, but a patient with sepsis. You can see, look at the lungs, but look how bright the adrenal glands are. The bright adrenal glands is a very good sign of impending shock or current shock. And it can be associated with the findings of a flat IVC, very bright bowel enhancement, all the things we think about with hypoperfusion. But sometimes it's the earliest finding you will see. So I think it's a very important finding, because if I see very bright adrenal glands, then I can call up the clinician and say, is this patient hypotensive? I've seen it a couple times in patients who've had contrast reactions. They had delayed contrast reactions, but this was the earliest finding. So if you see very bright adrenal glands, you have to worry. Now, it's not a feature related to how fast you inject or how much contrast you're injecting. It's just the adrenal glands are very bright and persist from arterial to venous to delayed. Now, sometimes you can have very thin adrenal glands. In this case, it's actually very hard. Look at the coronals. It's really hard to see the adrenals. They're really pencil thin. And this is adrenal atrophy. Okay, so we see that once in a while. You could see that particularly with patients with brain tumors like this patient had. And it can be very important, because it would be a good sign that the patient's going to have adrenal hypofunction. So that becomes very important. So going back to evaluation. So what am I thinking about? Clinical history is important. There's no doubt patients hypertensive. They have a history of lung cancer. They have a history of lymphoma. Often just looking at the clinical history, you can guess what the lesion's going to be even without looking at it. So that becomes very important. But to me, size is critical. Usually 4 centimeters is a magic number, because we typically don't think about adenomas above 4. And the rules are typically under 4 with a 60% washout. It used to be 3, but now it's probably more like 4. So size is critical. Bilateral, you could have bilateral adenomas, you could have bilateral metastasis. Sometimes that helps, often it doesn't. We'll look at attenuation. We look for the presence of fat or calcification, and the enhancement pattern. And when we think about the adrenal, the enhancement pattern, we think about, yes, we could mention how vascular things are on arterial phase, but we're typically talking about washout values. When patients have functioning adrenal lesions or functioning clinical syndromes, when we see adrenal lesions, we're obviously thinking that's going to be the cause. Incidentalomas typically are the non-functioning adrenal masses, right? These are the ones we pick up in roughly 5% of the population. When you look at patients aging, when you look at patients with diabetes, you look at patients with thyroid disease, you look at patients with obesity, the number probably goes from 5% to 10%. And the higher your resolution scans, depending how carefully you look, you probably can see tiny adrenal lesions in up to 10% of cases. But 5% tends to be the magic number. Now, the reality is, if you have an adenoma, this is an older article, but it's a good article, 973 patients, consecutive patients, incidental adrenal mass with no history of cancer. Every one of those lesions was going to be benign. It also, in the article, will mention that the patients had no hormonal syndromes or symptoms. And so they basically said, hey, no cancer, no known cancer. You see an adrenal lesion, looks benign, it's benign. You don't need any follow-up imaging. And then there was a second article Corwin wrote when they found bilateral adrenal lesions. Again, no history of malignancy, no clinical syndrome. Again, the same thing, leave alone. Leave those lesions alone. The challenge, of course, is, as I mentioned before, the endocrinologist will make the point, just because it looks benign, how do you know without testing with lab values that it's not an incidental hyperfunctioning lesion? I know some institutions on their report will have at the bottom that this is an incidental lesion, but if warranted, lab values should be done. Now, I know at Hopkins, one of our endocrinologists wanted me to put that on the report. And I didn't want to, but I came up with a conclusion, which was that I said, I'm happy to do it, but that means we see 50 or 60 adenomas a week. You're going to have 60 more consults. As I understand from the last meeting, you're backed up about 4 months. So what are you going to do? He goes, well, maybe hold off on putting that down. So it doesn't always work. The idea about size, and my next talk is on larger masses. This was an article from Mayo Clinic. I kind of like this article because these were all 4 centimeters or better. And in our minds, we think about malignancy, but greater than a third or around a third of all 4 centimeter or better lesions were adenomas, or another 16% were benign. So size does push you to worry, but even over 4 centimeters, at least half of the lesions are benign. So size alone is not really a great criteria. The other thing that often comes up is we see a lesion that looks benign, and the patient has a scan a few years earlier, and then they'll say, well, look, the lesion looks bigger than it did before. So one thing to remember, like many things, including pancreatic serous cystadenomas, benign lesions can grow. When we talk about myelolipomas, they will grow. Adenomas can grow. And the rule typically is, if it grows less than 3 millimeters a year, it's still benign. Malignancies or concerning lesions typically grow 5 millimeters or greater. So 3 millimeters or less, you don't need to worry about it, okay? That becomes very important. And again, you combine the size, you combine 10 Hounsfield units or less, that's what you're really thinking about. Now, again, one of the challenges, of course, is most of the rules about this 10 Hounsfield units were written on non-contrast CT scans. The reality is most of us do not have non-contrast scans. So that's really where everything changes, and that's why the whole idea about washout values. Adrenal lesions that are adenomas, with one exception, are going to wash out about 60%. So just a simple thing is this. Here's a non-contrast scan, a lesion about 3 centimeters, very well defined. It looks low density. In your heart, you know it's benign. You measure it, it measures 0 Hounsfield units. That's an adenoma. You don't need to give contrast to prove it. No problem. Another case, left adrenal lesion, you measure it, it's 6 Hounsfield units. It's a benign adenoma. Next case. But this was not a case for looking, this was an incidental finding because this was to look for a renal mass in a patient with hematuria. So we also had arterial phase imaging. So you see, if you would have looked at this lesion on arterial phase only, you would say it's 67 Hounsfield units, or venous, it's 56 Hounsfield units. So you would have worried. There's no way you could look at the arterial or venous phase alone and say this is benign. Forget about it. That's the challenge. Now, when you have delayed scans, it was 18 Hounsfield units, and so the washout value ends up being over 60%, 6 to 67 to 18. So from a protocol perspective, what do you do when you look at washout values? You have non-contrast, and hopefully you can stop there. Then you get, if it's indeterminate, you give IV contrast 100 cc's, injected at 4 cc's a second, and then you get venous phase imaging, 70 seconds. So you measure on the 70-second scan, and then you go at 15 minutes. People have tried going at 10 minutes. Your accuracy is about a third less. So you go at 15 minutes. It's the only thing we wait 15 minutes for. And the washout, you follow the curves. And that works out very nicely. As I mentioned, someone tried to do 10 minutes, but the accuracy wasn't very good. The thing about the washout also is it works really well for patients with lipid-poor adenomas. Here is a lesion that was 24 Hounsfield units non-contrast, so you couldn't call it an adenoma. It could be a pheo, it could be a met, it could be anything. But with contrast, it goes to 56 and then washes out to 28. So high washout value, a fat, poor adenoma. Now, one thing to remember about those washout numbers of 60%, when people wrote the original articles, and I don't often show articles from 2006, but this article was a good one because this was one of the articles that came up with the washout values, and they made the point that we ignored all pheochromocytomas because everyone knows what a pheo looks like. As I mentioned, pheos present with low-density lesions as well, and so you really need to be careful. And so one of the rules we have is when you look at the non-contrast and then you do venous phase, if the lesion enhances above 110, some people say 120, but I like probably in my heart to use 110 as a number, you have to worry about a pheochromocytoma. Typical adrenal adenomas do not enhance above 100 Hounsfield units. They surely don't go above 110 or 120. That's when you really have to think about a pheo. So here's an easy lesion, a very small lesion, 39 Hounsfield units. Maybe it's a lipid-poor adenoma, but then when you give contrast, it's 121. That just doesn't work. That was a pheochromocytoma. Now, the thing about adenomas, the problem is that things often don't follow rules. This was a patient who presented with back pain to multidisciplinary conference. There's a large 10-centimeter right adrenal mass. I have to admit the first thing I think about is that this looks like a carcinoma. Patient had no history of anything, no symptoms, just this back pain. But, this looks like a bad lesion. If you look at it, it has some peripheral enhancement. I'm not exactly sure what's going on in the lesion, but I'm surely worried about malignancy. This was resected. This was an adenoma. So just to make the point that sometimes you follow all the rules, there's no chance in hell you're going to be able to diagnose that adenoma. I'm not going to say this is a leave-alone lesion. I don't care how confident I ever become. It's not going to happen. Now, one thing to mention, there was an article published a few months ago about management of incidental adrenal nodules. And this article made the point, what would you recommend for incidental 1.7 centimeter right adrenal homogeneous nodule measuring over 10 Hounsfield units of non-contrast CT and no history of cancer? Remember, we spoke about they need a washout value. What this article showed is that there was significant variability. Some people recommended no further workup. Some people said do an adrenal protocol, which we would agree. Some people said do nothing. Some people said do MR. So one of the things this article showed that even though there are rules, people often don't follow the rules. Now, I mentioned about the neuroendocrine societies and the endocrine societies. And again, what they recommend in their follow-up is that you should get lab values. Now, again, I don't think people follow that, as I mentioned, because who's going to manage all those patients and who's ordering all those lab studies? Okay, other benign lesions, adrenal cysts. Adrenal cysts are not that common. They look very much like pancreatic cysts and liver cysts and all the renal cysts we spoke about. Very well defined. They can enlarge over time. Usually there's no definable wall. They can be in that 5 to 10 centimeter range. What do you do about them? Sometimes patients will have symptoms and they will be resected. But that's typically when they get large. We know that from liver hemangiomas. They're benign lesions. 10% of people have them, but sometimes they get very large and they have to be resected. We talk about serous cystadenomas of the pancreas. They're benign lesions. They're not going to be malignant, but they get large. You have to resect them. And adrenal cysts may be the same thing. Patients have symptoms. But, here on the arterial phase, on the non-contrast, water density, well-defined, no thickened wall, no septations. It's going to be a leave-alone lesion. There have been several articles about that, and there is sort of an increased incidence, this article mentions, of adrenal cysts. Now, occasionally, adrenal cysts can calcify. I have to admit, if I see this case, and I read this case, it was an adrenal lesion, I said it was an old hematoma, because to me, anything that calcifies is an old hematoma, be it in the spleen, be it the kidney, be it the adrenal. This was resected. It was an endothelial cyst. So every once in a while, benign cysts can calcify, but fortunately, you're not going to confuse this with a malignant lesion. Now, people have written articles now talking about cystic lesions, and I'll show you some examples in a few moments, that you need to be very careful because not every cystic lesion is benign. Just because centrally things are cystic doesn't mean anything, and particularly pheochromocytomas can be very cystic centrally. Adrenal carcinomas can be, but a little bit less common. Okay, another benign lesion is myelolipoma. Myelolipomas are benign lesions, typically in older patients. Their only issue is they can potentially bleed. And so typically over 5 centimeters, they will be resected because of that potential. They never become malignant. They can be confused at times because they can have brown fat and then they can be hot on PET. So all of a sudden you're looking at a patient with a lung cancer. For staging, you have a PET scan and the adrenal is very hot. And then the first thing everybody says, the patient has metastatic disease to the adrenal gland. Well, the fact is myelolipomas can be hot on PET, so you need to be careful. And this operation, when do you operate? Obviously, pain is always a reason. Pain is usually related to prior recurrent bleeding. Every once in a while, AMLs can be so large, or they look funny. They look like liposarcomas. That's pretty rare, but people speak about that. But again, the magic number is 5 centimeters typically. Here's just some examples real quickly. Here's a typical AML. It's all fat, maybe 2 centimeters. Here's a larger AML. Okay, this is 7 centimeters, but this haziness is present. That haziness typically means the lesion has bled previously, and this patient will likely get laparoscopic surgery. Here's another example, prominent left adrenal gland, lots of septations, higher density, myelolipoma. Very simple. One thing to remember, and I'll speak about this a little bit later in more detail, if an endocrine surgeon recognizes the lesion as benign but needs to be resected like a myelolipoma, they do laparoscopic surgery. Patients in the hospital for 1 day, very fast recovery. If they worry about malignancy, then they do an open procedure. When you do an open adrenal resection, the patient's in the hospital 6 to 9 days, and they have tremendous post-operative pain. So we try to do laparoscopic surgery, which is why it's so important for us to be able to be very specific whether we're thinking about a benign or malignant tumor. Now, the cases I showed you were mainly all fat, but not all myelolipomas look like that. Here's the ones people have more problems with, where it's just a little bit of punctate fat there. But what's important in this case, there are also calcifications. So one of the things I feel very comfortable about, if I see an adrenal mass, and they're typically in the 5 cm range, and they have macroscopic fat and punctate calcifications, it's a myelolipoma. I'm just not going to worry about it. People will say, well, you can have macroscopic fat theoretically in ACC. You can have calcifications in ACC. But well-defined lesions, macroscopic fat, well-defined, and punctate calcifications, to me, is always going to be a myelolipoma. And here's just one more example of that. So again, to me, it's a leave-alone lesion. I mentioned about hemorrhage. This patient presented with right upper quadrant pain, thought it was acute cholecystitis, big right adrenal mass, high density. That's a classic adrenal myelolipoma. With bleeding and based on size, the patient will get surgery. Here's an example of, I mentioned before, at times where someone could bring up the point, am I dealing with a liposarcoma? This was a myelolipoma, but you could imagine it's really large, it's kind of infiltrating. It can be a bit more of a challenge. Now, I mentioned about hemorrhage. So let's just talk a little bit more about hemorrhage. I mentioned myelolipomas can bleed, and that's a reason for resecting them. We always think about hemorrhage in a patient who's had trauma. Right adrenal, most common, is involved, typically associated with renal and liver lacerations as well. But adrenal hemorrhage can be, for many different reasons, can be unilateral or bilateral. When it's bilateral, it's a critical diagnosis because it can result in adrenal insufficiency. And bilateral adrenals with insufficiency present with symptoms ranging from acute abdomen to sepsis to myocardial infarction. The clinicians never recognize bilateral adrenal hemorrhage. So what things bleed? Underlying tumors, metastatic disease, for example. But patients on anticoagulant therapy is probably the most common reason for bilateral bleeds. Trauma, but trauma is usually unilateral. Infection, more unilateral than bilateral. Hypercoagulability states and stress. In terms of tumors, the most common tumor to bleed would be a pheochromocytoma. Mets, particularly renal cell, can bleed. ACCs can bleed, and I mentioned myelolipomas and adenomas. When you look at the literature, the most common presentation, particularly for trauma and for most things, is kind of an oval lesion, 3 centimeters. Often there's haziness around the adrenal, which helps you really think about the fact it's a bleed. Here's a good example here. This was due to Coumadin, but here's the left adrenal, looks normal. The right adrenal is large. It's relatively lower density, but you have all this stranding around it. If I read this case without a history, I would have assumed this patient had trauma, but trauma and bleeds due to Coumadin can look identical. Here's a patient with bilateral adrenal bleeds. Most likely that's going to be due to Coumadin. Now again, with bilateral bleeds, as I mentioned, you have to worry about adrenal insufficiency. And so, for example, in this patient who had a meningioma resected, they called me up and said, well, the patient had a benign tumor, surgery went well, the patient seems like they're dying, look for some source of sepsis. We saw bilateral adrenal masses, they're high density, very simple. I called upstairs, nothing very special for us, bilateral adrenal hemorrhage, patients probably Addisonian, which they were. Now, I've never seen a requisition rule out bilateral hemorrhage patients Addisonian. I've never seen that, except when you make this diagnosis, this always becomes the next grand rounds case. And the person who does the grand round case said, well, this is obviously bilateral adrenal hemorrhage and secondary Addison's disease. And for the next 3 weeks, you get about 30 requisitions. Rule out bilateral adrenal bleeds, and you don't see one for another 6 months. Now, the problem with bleeds can be cases like this. This patient presented with flank pain and a large mass. I'm thinking tumor. This was resected. We cannot figure anything out. It wasn't vascular. Patient had no hormonal abnormalities. This was resected. It was a large hematoma. Here's another patient with flank pain, large bleed. One of the challenges is once a patient bleeds, an underlying tumor is hard to see. So there's a recent article that made the point that when you have a large hemorrhage, perhaps follow the patient up 6 to 12 weeks later. You have to follow the patient, but following them immediately is not going to help. That patient had metastatic lung cancer. They had no knowledge of lung cancer. We found it on another study. But when you see a large mass that bleeds, you have to worry about that. Prior hemorrhage, you can see calcified glands, kind of the appearance we think about with TB perhaps, small atrophic glands that are calcified, or a larger lesion here, which is calcified. That's kind of the sequela. Now, last thing I'll just mention, I'll start on, or at least touch on, pheochromocytomas. Pheos are great mimickers. This was an article we published about a year ago. Pheos are very common, or not uncommon, and although everyone always felt they presented with syndromes or symptoms, that's really not the case. Remember, pheos have the rule of 10, multicentric, 10% of the time, 10% are malignant. They occur with a number of different syndromes. When they occur with syndromes, they're commonly bilateral. When they're just incidental pheos without a syndrome, they're typically unilateral. And this is an article from Hopkins. 70% of our cases of proven pheos were picked up incidentally. So you always have to think about a pheo, and they're in fact really great mimickers, okay, because you often don't think about them. They have the key with pheos, I mentioned before, is going to be the vascularity. Classic pheos are oval, hypervascular. At that 70-second mark, they'll be between 120 and 250 Hounsfield units. So that becomes very important. As I mentioned, they do wash out very quickly. So if you just go with washout value, even a pheo that enhances to 200 Hounsfield units will most commonly have a 60% washout value if you go to 15 minutes. So the washout value does not matter. When you break 110 or 120, whatever number you want to use, you got to think about pheochromocytoma, and invariably just get lab values and you'll prove it. Again, in patients with different syndromes, we think about it. 10% of pheos will have calcification. I think sometimes pheos overlap very nicely with primary carcinoma because they can be very large. Here's just a simple example. I'll just show you a few easy cases. Incidental right adrenal mass could be most anything. It measured about 40 Hounsfield units non-contrast. Here it is, arterial phase. Look how vascular that lesion is. You can see very nicely here and here. But look how it washes out. The washout was 70%, but the venous phase imaging makes that a pheochromocytoma. Here's one on the left side. Non-contrast, this could be almost anything, but it's very well defined. There's nothing to make me think about a pheo, but it's not an adenoma, just based on measuring, because again, it's around 40 Hounsfield units. Here it is with contrast. It's 150 Hounsfield units. I don't need to think any further. If you ask me, okay, and you say, okay, this is not a pheo, when I do a quiz panel and they say, okay, you're wrong, it's not a pheo, then I would say metastatic renal cell carcinoma. So the only thing that really gets as bright as a pheo is metastatic RCC. But look at it, 150, look how bright it is, but look at it on the delayed. It's 59 Hounsfield units. So again, a 60 to 70% washout value, but the early phase tells you it's a pheo. Here's another one. Again, look at that right adrenal lesion. 2 centimeters, it looks like something you just are going to pass up, but you measure it's 30 Hounsfield units. You just can't say advised clinical correlation. This patient needs an adrenal protocol CT, and when you do it, it measures 280 Hounsfield units. It's like a light bulb, right? There it is there. There it is on the cinematic rendering. But again, look how it washes out. Now, one pitfall with pheos, I mentioned this before, is the last 3 cases I showed you are the classic pheos. But pheos can also be cystic lesions. When they're cystic, I think I have more problem because then they often push me to things like ACC. I'm not going to call this a simple cyst, right? Because there's wall thickening, there's wall enhancement, and these areas of enhancement here. So there's no way that's going to be a simple cyst, but it's some sort of cystic tumor. So you think about metastasis, particularly melanoma. You got to think about an ACC, that can be cystic, but you got to think about pheochromocytoma. Here's another one, presents with a lung nodule. Look how vascular the lung nodule is. Look at this mass in the right adrenal. Again, if you said adrenal cortical carcinoma, I think that's great. That would be a really good answer. But this was a cystic pheochromocytoma. So when you think about vascular cystic lesions of the adrenal, you got to think about surely an ACC, but you got to think about pheos. And it's easy to tell the difference. You're not doing a biopsy, obviously. Just look at the patient's metanephrine levels and you'll have the right answer. This patient was not symptomatic for hypertension, so it wasn't like they were presenting. But look at the vascularity and the neovascularity in the lesion, and look how it washes out. Really central cystic. If you show me that image alone, I'd be thinking ACC. So it's really, really important. So pheos have this range of appearances, and they can be a real challenge. So what I'll do is stop there, and what I'll talk about in the next talk is some of the larger lesions and some of the challenges. So Again, adrenal protocol CT is the modality of choice for evaluating adrenal masses, knowing the positive and the negative, knowing some of the potential pitfalls, I think will help you do a great job. But I will say, lab values are important, clinical history is important, and sometimes with the lab values, with the history, and with the imaging, we still can't make the right diagnosis. And the patient goes to surgery, we get the path about a month and a half later, and we say, it was obviously that. And with that, I thank you very much.